welcome to the Stronger After Stroke podcast. I'm your host, Rosa Hart, and with me today is Dr. Tamika Burrus. She is a vascular stroke neurologist here with us at the Norton Neuroscience Institute, and I'm really excited to talk to her today. We're going to focus on women and stroke. This is part 2 of our series that we started with Dr. Burrus. So if you missed the episode with Dr. Rabia Burrus, be sure and go back and hear that so you get the full context and the full benefit of both of our female neurologists talking about women after stroke. So thanks so much for taking your time to be with me today.
Thank you for having me.
So let's pick up where we left off. So are there differences in how women respond to stroke treatments like TPA or thrombectomy?
So there are not differences in how women respond to the therapy. Historically, we had noted that there had been differences in access to receiving the therapy. So women were not having the same door-to-needle time. So when they came into the emergency room, they weren't receiving the clot-busting medication, which is TPA, or they weren't receiving the surgery, mechanical thrombectomy, where we take a catheter, go through the groin artery up into the brain to remove the clot. In the past few years with research, that has narrowed the gap, and so we don't really see that. Now, what we do see, though, is after stroke, women tend to do worse than men, and there are several reasons for that. First off, women are older, so just in general, an older person is going to have more disability, more difficulties recovering. Women are older because they live longer than men. And we know that estrogen has a protective effect on cardiovascular disease in general. And so, of course, on stroke as well. And so essentially, what we see is that women are postmenopausal predominantly having their stroke. And so they're not recovering as well. They're less likely to be presented to acute rehab than men. And so they don't have the intensive recovery that men receive as well.
So there are a couple of things I'd like to clarify with that. So when you say women are older, do you mean most of the time when we see women who are having strokes, they tend to be older than like the average age of a man who's had a stroke? Is that kind of what you're looking at?
Correct, yes. And so one reason is because of the effect of estrogen. So women are having the stroke postmenopausal, sort of older age. Mm-hmm. The other reason is because women live longer. And so part of that is because men have jobs that are riskier. Usually, men also engage in more riskier activities than women, like more men rock climb than women, as an example. And so they don't live as long because of that. Women go to the doctor, they go to the nurse practitioner, to the physician assistant more than men. And so they're kind of taking care of themselves a little bit longer. And then lastly, women have a more robust immune system than men. And so that's protective for pregnancy because you want to protect the baby.
Yeah.
And so women don't get as many infections as men do throughout their life. And so they're living longer because of that. Wow. On the flip side, because the immune system's so robust, women get more autoimmune disease, which then leads to stroke as well, such as lupus.
Yeah. And I'm looking forward to seeing more research about what we can do to help women with autoimmune disease, since it is so much more prevalent in women. Since we're talking about estrogen, I believe we mentioned this back in the conversation with Dr. Burrus about how hormonal birth control can actually increase stroke risk.
Correct.
So could you kind of explain how that works, how estrogen and birth control could increase your stroke risk, but also estrogen can be protective to your cardiovascular system?
So that's really interesting. It's hard to say exactly the correlation because we just know that women who, for instance, have migraines, who have holes in their heart called patent foramina valley, tend to have more stroke if they do take exogenous estrogen versus women who have endogenous estrogen tend to have a more protective effect.
And endogenous estrogen would be naturally created by
Correct.
your own body,
Correct.
like in your ovaries, not supplemented from
Correct.
an external source.
Correct.
Okay. Well, it's amazing how it's like sometimes we have to take things that aren't naturally occurring in our body, like sometimes you got to take baby aspirin to keep from having a stroke, but
Yes.
maybe not estrogen. So we'll move on. And do women face different recovery challenges after stroke, physically, cognitively, or emotionally than men do?
They do. We see in the studies that physically they have more difficulties. Part of that is because they're older. And part of that, as mentioned before, is because they're not going into intensive rehab as much as men are in terms of the referral process. And then in terms of emotionally, we see that women have more post-stroke depression than men. And we see that women, in general, because I think, as mentioned before, tend to be more caregivers. And so there's more of this backpack burden that women carry with them of chronic inflammation that then translates over to their post-stroke recovery.
Yeah, I definitely see what you're talking about when I speak with my stroke patients in the follow up process or in talking to the caregivers, which is often the spouse or the daughter, usually
Yes.
like the oldest daughter. There she is. Right, same. So, when you said referrals for like rehabilitation and things like that, what are you seeing that would get women less rehabilitation after a stroke?
So I think, again, that is multifactorial in terms of they are older, so they're going to have more disability from their stroke just by the nature of being older. But then for reasons that aren't clear, they aren't being referred as often as men are. Just in general, women aren't necessarily always taken as seriously as men in terms of how they're feeling, whether that be around pain or their disability with their stroke. And so that translates into that. And then sometimes they don't want to go because, again, they are the caregiver and they feel, oh no, I have to go back home. I can't, I'm going to do outpatient rehab. I actually had a patient recently who they recommended acute rehab, and she just flat out refused because, no, I have children at home. I've got to be there for them, et cetera. So,
And that's something that I've spoken with a lot of people about too, is that when women are the caregiver, like if a husband has a stroke and he has a wife there to take care of him, she's going to make sure that he takes his medicine and gets to all
correct.
his appointments and everything. And women are very attuned to that caregiving tendency. And men are not always that way. And if these women are older and their spouse is unable or has passed away to take care of them, and they don't have that support at home, making sure they take their medicine and get to their appointments, then it would make sense that they wouldn't get as much help. So I'm glad you pointed that out. And it's not just me and my phone calls over here.
Yes.
So, would you say that there is any kind of disparity in access to stroke rehab for women as far as getting approved for it once referred? Or is it more, do you feel like, whether or not they accept it or they think to get the referral?
I think it really is a combination of all of it, to be honest.
Makes sense. Yeah. Just want to make sure I'm not leaving a
Sure.
stone
Yeah.
unturned there in case we need to advocate for policy changes. So, what are the most important lifestyle changes that women can make to reduce stroke risk at any age?
Sure. So I would say, first off, we think about high cholesterol. We know that high cholesterol can lead to both non-bleeding or ischemic stroke, as well as bleeding or hemorrhagic stroke. We know that just increasing your fiber intake can be very helpful in lowering the cholesterol. And so we recommend more Mediterranean-based diet, taking your medications. The second thing would be if you have diabetes, control of your diabetes. That doesn't mean a zero sugar diet. It really means like just picking foods that are more low glycemic index, meaning foods that when it goes through the bloodstream, it doesn't spike the blood sugar as high as other foods. So steel cut oatmeal is an example. Actually, fun fact, prior to the invention of insulin in the 1930s, oatmeal was part of the treatment for type 1 diabetics. And that's because that steel cut oatmeal, not that fast oatmeal, helps regulate the blood sugar throughout the day because it's so high fiber. And so, again, food is very important in controlling your diabetes, taking your medications. And I think my colleague, Dr. Burrus, touched on this as well, which is, once again, blood pressure, blood pressure, blood pressure. And so when we think about blood pressure, we have to think about sleep as well. And so we have to think about obstructive sleep apnea. So being treated for that. I think a lot of times people think about it and they're like, I don't want this mask on me, just forget it. And they don't realize when they stop breathing, the blood pressure goes up. And then it does it again and again. And it's happening all night long. And then that leads to heart failure. And that leads to stroke. And so treating sleep apnea is very important. The other thing, getting back to women as caregivers, especially if you're a stay-at-home mom or a working mom, or just a woman in general caring for, all of your friends and relatives, because all women tend to have this caregiving role based on how we were socialized as little girls. What we find is that they don't get a lot of sleep. And back when I was in medical school, we didn't know that there is a system called the glymphatic system. And the glymphatic system essentially clears out toxins. And it works when you're sleeping. And so if you're not getting good sleep, you're going to have a buildup of toxins. And what that does is it causes something called small vessel disease. And so basically that just means that you have these large arteries in your brain and you have these little tiny ones that come off of it. And if you don't get the sleep that you need, those arteries get very narrowed or they pop, and that leads to either a bleeding or non-bleeding stroke. So we know sleep is critical. We recommend 7 to 9 hours of sleep a day. And then lastly, and people aren't going to like me for this one, but alcohol. So during COVID, a lot of people started drinking more because they were bored, lonely, whatever. And in particular, women did. And we know that women from like the 40s all the way up to what I like to call the silver tsunami, so women that are in retirement age, drink a lot more than they used to. And we know there's a lot of marketing around that. A lot of drinks that are in pink, and let's do girls' night, let's do sip and wine, etc. Or art and like sip and art or whatever it's called, but where
you paint and you drink wine together.
Right, yeah, exactly. So there are a lot of events around drinking, and unfortunately, alcohol is bad. All alcohol is bad, and for the brain and for the body. And so alcohol raises your triglycerides. That causes narrowing in the blood vessels. That causes stroke. Alcohol changes how the blood flows. That causes bleeding stroke. Alcohol also increases stress hormones, which then lead to high blood pressure, which then leads to bleeding or non-bleeding stroke. And so recommend, in general, women cutting back on alcohol. Even 1 glass a day is considered harmful for women.
Yeah. And there are so many great mocktail options now. I would say that that's one thing Gen Z has going for it.
Exactly.
Gen Z is actually looking at pushing some of the alcohol businesses into less profitability because they're actually really fixated on their health. And they've designed a whole lot of different mocktail options, and there's some really cool ones that you can make that are pink or other fun colors, or they even change colors. So if you want to have a fun drink night, you can do it. So just a side note here.
And we also just recommend other ways of increasing those endorphins, dance, just socialization itself.
Socializing, definitely. You don't want to give up your socializing, so you can alter it a little bit. Let's see. Are there specific populations of women that are higher risk, such as Black or Hispanic women, and how can healthcare systems address those disparities?
Great question. So definitely Black and Hispanic women are at higher risk for stroke. particularly because they have less control of the risk factors, particularly blood pressure. So they're more likely to get preeclampsia, gestational diabetes. They're also less likely to have access to health care. That's why one of the great things that we have here at Norton now is a new hospital on the west part of Louisville. And before it was a medical desert for, I think, over 100 years or something. And studies show it is important to have health care in your neighborhood and community. And so now the stroke team is able to collaborate with the ER physician assistant, nurse practitioners that are seeing the patients in that community to provide acute stroke care for them. And so I think that's one of the things that healthcare systems across the country can do to mitigate this. I think that, what we find is even though if you receive the clot-busting medication, tenecteplase, alteplase, or mechanical thrombectomy, the procedure, everyone gets like the same treatment. The issue is that oftentimes, in particular with our Black population, they don't want the treatment. Part of that is because from the 40s to the 1970s, there was the Tuskegee experiment, where the United States essentially monitored, observed Black men with syphilis and didn't offer them the treatment, penicillin. And so, they spread it, they had complications, et cetera. And so in the Black population, a lot of people are very hesitant to take the medication. So you're in the emergency room, you're weak on one side of your body, this person's in front of you saying, hey, we have a medicine, 30% of patients will improve with it, 6% will get bleeding in the brain, 3% will die, and you're like, wait, what?
Because you have to provide informed consent.
Correct.
Yeah.
And with Tuskegee, there was no informed consent, which was why it was considered not morally correct to do. But, you're not necessarily going to be having active chest pain or short of breath where you're like, oh my God.
Where you feel that urgency.
Right.
It might be like you're not able to lift your arm.
Correct.
But it's also not hurting because you may not be able to feel it at all.
Right. Or some strokes you don't even realize because of the location of the stroke that you actually have the disability.
Right.
Like you have neglect. You don't realize, oh, half of my body is not moving. You don't.
It's apparent to the people around you when you have neglect, but then you yourself can't. But if you're getting the consent from the person who is experiencing the stroke and they don't even understand the severity of what's happening to them, it can be tricky if there's not already that established trust.
Right. So it's so important for us just right from the get-go to establish trust and rapport. And because you lose 2 million brain cells a minute when you're having a stroke, we have to do it very quickly. So I like to provide good eye contact, make sure the family's involved as well, and really just reiterating that this is the standard of care. Because when you think about your visit to the emergency room, it's really the only drug where we're doing this, where you're not in necessarily sometimes, but not always in hemodynamic instability, meaning,
your blood pressure is usually controllable. Well, actually, in order for you to even offer these treatments, your blood pressure has to be within safe, established parameters. Could you share with us some of the other, the list you guys have to go through before you will even make that opportunity available to them? Because before a physician or neurologist offers tenecteplase or alteplase as a clot-busting medication for stroke, they've already gone through a list of criteria to eliminate other risk factors, like check to CT to see if there's bleeding in the brain.
Correct.
And measured the blood pressure to make sure that it's not too high for it to rupture. And also made sure they're not on any blood thinners already, because you can't layer a clot buster on top of that. But what am I leaving out here?
Yeah, we also look to see, have you had surgery recently? Have you had any GI bleeding? Do you have a history of a bleeding stroke? And then the most important thing, and some other things, but the most important is, when did this happen?
Yes, the
Like,
time
did
frame.
you wake up with this, or did you wake up and this happened? Because we can only give it to you within 4.5 hours for the most part. And so it's a very quick process, and I can appreciate how it will feel chaotic to the patient, but it is very methodical. And there's a huge team for the hospital system that's developed the process. And we definitely encourage people to show up. And I understand too, because it's like, oh, my tooth isn't hurting. I'm just numb on one side. And especially just getting back to ethnic minority populations, it's like, well, there's some socioeconomic factors too. Do we want to call 911?
Yeah.
There's a big bill there. And I like to tell my patients, look, a bigger bill is a nursing home for the rest of your life, or funeral arrangements. So it is best if you develop acute numbness, tingling, weakness, difficulty walking, talking, to just call 911.
Definitely. And I just would love to reiterate the fact that if someone is getting to the point of offering you this clot busting
Right.
medication, they've already weighed the risks and benefits of
Yes.
whether or not they're willing to risk their medical license to give it to you.
For sure.
So if it's being recommended, it's not being recommended lightly. And they're just providing you with information about the risks for informed consent purposes. So thank you so much for explaining that, because I feel like that's not something we've been able to really cover yet on the podcast, because a lot of the time we're really focused on just the recovery after. But at the same time, most people don't care about preventing stroke until they've had one.
Right.
And they're obviously at risk for another one if they've had one, and then will care to tell their family members about this process and be their family expert. So I'm really glad you were able to share that context. Sure. So since we're talking about how much pregnancy related risks are with women in stroke, how can primary care and OBGYN providers better screen women for stroke earlier in life?
So I think, again, focusing on the risk factors, looking at the population in front of you. Even for myself, when I used to do a lot of telemedicine, on the screen, I had 2 words: women and minority. And that's because studies show, even if you yourself, as the physician, are female and, an ethnic minority, you have the same bias that anyone else has. That's what the studies show, because we all grew up in the same environment. And so I want to remind myself and pause, hey, take it seriously equally. I mean, because there's no intention not to, but I know that there's unconscious bias that we all carry every day about everything, essentially. And so I think for the family medicine, physician, nurse practitioner, PA, or OB-GYN specialist, recognizing that, and then making sure when they're in front of the Black or Hispanic patient, or the patient that doesn't speak English as a first language, that they're really taking a step back and addressing the risk factors of blood pressure, cholesterol, diabetes. For patients who have endometriosis, those patients tend to be diagnosed more that are Asian, and making sure that they're addressing it in them as well, because we know that endometriosis causes chronic inflammation. We don't know exactly how that leads to stroke, but there does tend to be more women who have endometriosis also have more non-bleeding stroke or ischemic stroke.
Wow. You teach me something every day, every time I talk to you. This is amazing. What is one misconception about stroke in women that you wish more people understood?
Women get strokes.
Yep, true. They sure do.
Yes.
And if a woman has had a stroke, what are the most important next steps she should take in recovery and prevention?
I think the most important next step is Well, I am a big advocate of the concept of food as medicine.
Yeah.
And so I really think if you have a stroke, just, okay, it's time to take a pause and to reevaluate, like, what are you eating? What are you taking inside of you? We as physicians can give you medication, but if you're having processed foods, if you're having a lot of red meat, those are all very pro-inflammatory foods. And so it's just going to, counteract the medication that we're giving you. Even if we make the numbers look good, it's still causing a pro-inflammatory state in your body and in particular in your brain. So I recommend people just focusing on a more Mediterranean-based diet as a way to prevent stroke, moving more. As people get older, we know that they become more isolated. So kind of forcing yourself to do more socialization, whether that's with a spiritual group or a dance group or what have you, but just getting out there. And it's challenging as you get older. It's hard to put yourself out there, but we're all human beings, and really everyone wants to connect and to have connection. So just take the risk.
Yeah, that's another dancing reference. I'm about to have to ask what kind of dance groups I need to find out that Dr. Burrus might go to. But let's see. Now, as you were talking about the Mediterranean diet, if you refer back, we have an episode with a dietitian who talked about the Mediterranean diet and how to read labels of food to make the best choice out of the options that are available to you. Because, some people can't go to Whole Foods and get everything organic. So if you're choosing, for example, between canned foods, how to make the best choice. So please check that episode out, and there should be a printable PDF available in the show notes as well. You can print out and take that with you to the grocery store or wherever you're shopping for groceries if you have it delivered. Keep that as a reference. And yes, and I think you like to use that list too, right?
No, I definitely do. And not everything has to be organic too. So, things that are typically like where you has its own skin and so forth that you're not eating. They have a whole list of what you should maybe look more towards organic and what you don't have to. And grocery stores like Aldi too tend to be more affordable and have more organic products. But I feel like all the grocery stores these days have like a section for that. I definitely try my best, but I'm totally imperfect.
Hey.
So I would say that my biggest advice too is don't let perfection be the enemy of good. So try your best every day. If you've had a stroke, don't think about what you should have done because that leads to depression.
Yeah.
Don't think about tomorrow, what you should do, because that leads to anxiety. Just focus on today, and each day wake up and try again. And if you get it like right 70% of the time, you're doing awesome.
That is so
So
beautiful.
yeah.
So I think that is just the perfect thing to close on.
Oh,
I
okay.
mean, like, live in the present and do the best you can today. And feel free to check out all the other episodes of the Stronger After Stroke podcast for more insights and encouragement so that you can have your best life after stroke. And feel free to subscribe wherever you are listening and leave us in the comments if you have any questions that you would like us to answer in future episodes. And thank you again, Dr. Burrus, for being with us.
Thanks. Thanks, everyone.